Hey everyone, welcome to this explainer. Today, we're taking a highly technical but absolutely crucial document, the World Health Organization's medical eligibility criteria for contraceptive use, specifically the 6th edition, and we're turning it into a dynamic, everyday clinical tool. If you're prescribing or counseling patients, this is literally your ultimate playbook for safe, evidence-based care. We're going to break down some seriously complex medical conditions to see exactly how the WHO guidelines navigate that tricky balance of risk and safety.
Think of today's session as our clinical rounds. Here's our patient chart for the day. We're going to start by decoding the MEC itself, handle sepsis with IUD restrictions, navigate the complexities of lupus, review post-molar pregnancy guidelines, and wrap up with the repeat use of emergency contraception. Let's get to it.
Okay, Section 1. Decoding the WHO MEC. Let's dive right in and establish the ground rules for our clinical rounds today.
So, the WHO MEC uses a 4-tier system, right? But today we're really just focusing on the extreme ends. MEC Category 1, that's your definitive green light. It means there is absolutely no restriction for using that contraceptive method. It is completely safe. But on the other end of the spectrum, we have MEC Category 4. This is a hard stop, an absolute contraindication. A Category 4 condition represents an unacceptable health risk to the patient. Keep those two extremes in your head as we evaluate these cases.
Section 2, Sepsis and IUD Restrictions. All right, let's open up our first patient file.
Here are the stats for case number 1. Picture this. A 28-year-old woman is in the ED being treated for a severe septic abortion following an unsafe procedure. She's currently on broad-spectrum IV antibiotics, and she's requesting a copper IUD for future contraception. So, based on the WHMEC 6th edition, what's the category for immediate insertion of a copper IUD for this specific patient? Take a second to lock in your diagnosis.
It's a Category 4. If you guessed that, you are absolutely spot on. It's an unacceptable health risk. But we have to ask why, right? It's all about the physiology. Being in an immediate post-septic abortion state is an absolute contraindication for inserting any intrauterine device, and that means both the copper IUD and the levonorgestrel-releasing IUD. Because think about it, placing a foreign body straight into an actively infected uterine environment, that carries a remarkably high likelihood of exacerbating the pelvic infection. It's just entirely too dangerous.
And this is such a brilliant example of how one single clinical variable can completely flip your protocol. Look, if this were just a routine first or second trimester abortion without any sepsis, inserting that IUD would be a Category 1 or 2, perfectly safe. But the mere presence of sepsis, that automatically violently shifts this straight to a Category 4. That being said, we still need to provide our patient with highly effective contraception. Fortunately, the WHO guidelines do offer a Category 1 solution here. Progestogen-only implants, like the etinogestrel implant, are MEC Category 1 in the immediate post-septic abortion period. You can initiate this long-acting reversible contraceptive immediately, without any restrictions, getting the patient the protection she needs while her infection resolves.
Okay, Section 3, Navigating Lupus and Contraception. Let's move to our second clinical case and see how this builds our understanding of complex systemic diseases.
Check out this next file. We've got a 26-year-old woman with systemic lupus erythematosus presenting for counseling. Her recent labs confirm she is strongly positive for anti-phospholipid antibodies, or APLA. Take a moment. Between oral contraceptives, injectables, hormonal IUDs, and copper IUDs, which method is Category 1 here?
Now, what's really interesting here is the breakdown of the cardiovascular risks associated with lupus and APLA. Women with this exact profile are at an extreme risk for arterial and venous thrombosis. Because of that, combined oral contraceptives are highly thrombogenic and land strictly in Category 4, no-go. Even progestogen-only methods, like the depot shot or levonorgestrel IUD, carry a theoretical risk of thrombosis, making them a Category 3. So that leaves the non-hormonal copper IUD as the only entirely safe Category 1 method for this patient.
But let's play what if for a second. What if our lupus patient didn't have APLA, but instead presented with severe thrombocytopenia? Well, because a copper IUD can induce heavy menstrual bleeding, placing it in a patient with severely low platelets who's already super prone to bleeding becomes really dangerous. Just like that, the copper IUD shifts from a super safe Category 1 down to a Category 3. It just goes to show how incredibly responsive the guidelines are to the specific symptoms of a systemic disease.
Section 4, Post-molar pregnancy guidelines. Let's turn the page to our third case, dealing with gestational trophoblastic disease.
For this one, we have a 24-year-old woman who recently underwent a suction evacuation for a complete hydantoin mole. Crucially, her serum beta-HCG levels are currently decreasing, even though they're still detectable. She wants a highly effective long-acting method and is asking for a copper IUD. So, based on her decreasing beta-HCG, what is the MEC category?
Category 1. You can totally proceed without restriction.
The WHO's limited evidence actually shows that women with decreasing or undetectable beta-HCG levels aren't at an increased risk of developing postmolar trophoblastic disease by using an IUD. So both copper and hormonal IUDs are Category 1. But here's the catch. If those beta-HCG levels were persistently elevated, which indicates a potentially malignant disease, inserting an IUD into that uterine cavity instantly becomes an unacceptable health risk. Boom, Category 4.
Section 5. Emergency contraception, repeat. All right, let's move to our final section, where we're going to bust a very common clinical myth regarding emergency interventions.
Imagine this classic real-world scenario. A 21-year-old requests an emergency contraceptive pill after a condom broke, but she tells you she already took a 1.5 milligram levonorgestrel ECP just 2 weeks ago, during this exact same menstrual cycle. So does repeating the dose within a single cycle restrict our ability to prescribe it? What's the MEC category here?
It is absolutely a Category 1. Literally no restriction.
The updated 6th edition of the WHO MEC explicitly evaluated this, the repeated use of emergency contraceptive pills within the same cycle, and the systematic review found no serious adverse events. There are no significant differences in pregnancy complications and absolutely no fetal outcome differences in overlapping study populations. It is definitively Category 1, so you can prescribe it without a second of hesitation.
But wait, curveball. Let's introduce one final clinical twist to see if we've really mastered these rules. What if this exact same 21-year-old patient came to you, but she currently had active pelvic inflammatory disease, and instead of the pill, she requested a copper IUD to be used as her emergency contraception? What category are we looking at now?
That is a Category 4. Think back to our very first case about sepsis. The physiological rule is exactly the same. Inserting an intrauterine device into an actively infected uterus, whether that's post-sepsion abortion or active PID, presents an unacceptable health risk. Period.
We have covered so much ground today. And honestly, what this all brilliantly illustrates is that the WHO medical eligibility criteria isn't just some static list of rules. It's a highly dynamic, living framework. We've seen exactly how tweaking just one single variable, like going from normal platelets to severe thrombocytopenia, or from decreasing beta-HCG to persistently elevated levels, can violently shift a treatment from being entirely safe to an absolute do-not-pass-go contraindication. So I'll leave you with this. How are you going to apply these dynamic WHO EC shifts to ensure peak patient safety in your next clinical rotation? Keep these principles fresh in your mind, trust the evidence, and I will see you in the next explainer.